How you doing, guys? It's Dermot from Physio here and my lovely physio Sarah. We're going to have a chat today about women's health issues. Now, over the next couple of weeks, we're going to do a couple of interviews with Sarah and Connor, and we're going to be covering topics: women's health, lower limb injuries, running injuries, hip pain, chest pain, all sorts of injuries that we're going to try and cover in these little bit of interviews. Hopefully, it'll give you a little bit more guidance as regards what physio can do to help you. And if you've been to other physiotherapists before, what we do a little bit differently. So just showcasing some of our skills as well at the same time. So what we're going to do is we're going to start off a couple of questions for Sarah. How are we? So Sarah, look at, before you came on, we saw a lot of people coming in through the clinics that had women's health issues that I generally started to refer on to other people. Now since you've come on, you've kind of delved into the subject a little bit deeper. So if you can kind of explain what are the most common types of issues you see with women post-pregnancy when they're coming into the clinic?
Yeah, so I suppose after people come in after they've had a baby, we generally see a lot of kind of low back pain, neck and shoulder tightness, issues with their pelvic floor, whether it's tightness or weakness, maybe they're getting a little bit of leaking, issues in and around the scar if they've had a C-section, whether it's a reduction in sensation or it's a little bit stuck and it's hard for them to kick in their core. And then sometimes they have that kind of deep glute or deep hip pain as well. So they'd be kind of the top most common things that we'd see. And generally that's kind of down to a number of reasons, I suppose. Like whenever you have a baby, everything changes and your body changes so much that whenever the baby's growing inside the belly, if you imagine here is Fred or skeleton
with a mask and everything.
With a mask, just to help you to understand it that little bit more. So your rib cage and your pelvis and the baby will be growing in and around here. So if you can imagine whenever you're growing that baby, that is coming out of the front, so the center of gravity is coming into the front. It's ending up putting your back into a little bit more extension and your ribs are coming forward for that baby to grow. So many things change between your breathing patterning, your rib cage angle, the way your ribs are sitting, the pressure on your pelvic floor, the way your pelvis is sitting, the muscles getting stretched in the front, the muscles getting tight in the back, kind of a little bit of instability in and around the hips and the pelvis. So it stems from, I suppose, that body and posture that you have whenever you are pregnant.
Yeah, it's a lot of the times that we see people come in as well and they don't realise that when you go, just go back to the scar, when you have a C-section, like they have to cut through an awful lot of muscles to get there. So number one, if you're growing a baby and then you start to get that lordotic posture, your rib cage lifted up into that position, your stomach muscles are already stretched there, and then what happens is the doctor comes in and he cuts through them all. So a lot of the people, like what do you see with the scar, like a lot of women are kind of shocked and kind of go, oh, it's just a scar, I just forgot about it. But what do you find with it?
So I suppose initially I feel like sometimes enough heed isn't given to actually how big and serious of a surgery it is, like it's a really
big
surgery.
Surgeries are hard, like.
So you're kind of thrown back in with no sleep, poor nutrition probably, you're lifting a baby around, so it's just not given that time to heal and recover as well as it could initially as well.
Yeah, mothers tend to do it. They always tend to kind of go, look, I'll be fine, but my baby needs attention, which is absolutely fine. But then when it comes a couple of months down the line and they're kind of going, I should be getting better, like, they're not really, like. And what we find is, like, I do the basic assessment to kind of have a look at that scar, see what's happening with the scar, but then the nitty gritty kind of fine tuning, getting some of those muscles to fire in certain patterns. That's where Sarah comes in with a lot of it. And you find that pelvic floor is kind of generally a lot of the bigger issues when it comes down to it.
As well. Yeah, so I suppose with the scar, whenever you're cut through the tissue, it's hard for you then to be able to kick in that core again. So even whether you've had a C-section or not, with the stretch in the tummy, it's quite hard for women, I suppose, to reconnect to their core. So what we kind of find initially that people want to learn how to do and what we need to do early on and just start with is getting that reconnection to the core, reconnection to the breathing and reconnection to the pelvic floor. Then it's about the strategies that they're using, so getting them all to work together and not against each other. So sometimes generally issues arrive further down the line whenever you develop these strategies when you're pregnant and you have that baby and you're not able to engage your core as well as you could. You develop these strategies to do things, so such as using your back instead of your tummy. Then that lingers after the baby's out, such as bracing and pushing down on your pelvic floor to create that stability for your back. Rather than kind of getting that good deeper contraction in the tummy and the lift of the pelvic floor altogether. So
Just to delve into that a little bit deeper, when
Yeah.
people kind of go and they think they're creating tension down through there, but what they develop a little bit of a dome when you try to assess they're doing, let's say they're doing Pilates or they're trying to get that tummy muscle back to working again. You see that dome of that rectus abdominis just kind of push out, but no stability underneath it. Why is that?
Exactly. So I suppose usually I find that this comes down to starting with the breathing. So if you think about that rib cage, that rib cage angle. So you have your diaphragm that sits right underneath the rib cage. You have your pelvic floor that sits just in the pelvic outlet there, and then you have your core muscles here. So if you have a think about when you're pregnant, the ribs are shoved up and out, so forwards.
Yep.
The muscles are stretched at the front. And then everything's kind of lengthened. So whenever you are breathing, your diaphragm isn't able to come down because that's where the baby was taking up the space. So it's kind of
the diaphragm comes down and the pelvic floor comes up as you breathe in, is it?
When you breathe in, the diaphragm comes down and the pelvic floor comes down. So they work together. So it's like two kind of diaphragms as such on top of each other here and here. When you breathe in, the diaphragm comes down to kind of pull air into your lungs like a syringe, and the pelvic floor should come down at the same time. When you breathe out, then the diaphragm lifts and pushes air out, and the pelvic floor lifts at the same time.
So that coordination is the mix-up.
It's the coordination that's the issue. So the first issue generally is they can't get the diaphragm to move as well as it used to because the baby was in the way. So it's about relearning how to breathe essentially and get that three-dimensional breath so that you're able to get a breath into your tummy, your back and into your sides, because that was all restricted and tight from the pressure of the baby, and then the baby was just in the way of the diaphragm actually coming down.
Just wasn't able to move, just didn't have the space.
Yeah.
And if somebody wanted to kind of, let's say, is my breathing off? What could they do to try and assess, to try and see if that diaphragm is working themselves? Is there anything they could do at home?
So I suppose a little test that you could use is, the last Instagram video that we posted was going through this as well. If you wanted a little bit more detail, if you wanted to have a look at that. But it's just lying down onto your back.
What's that titled?
Reconnecting to your core. So this is kind of going into how to, I suppose, look at what's happening with your core. If you do need to work on that breathing, if you do need to work on that engagement as well. But it's basically if you lie on your back and take a breath in, see, are you able to breathe into the back and side of your ribs? Does it flatten down onto the floor when you breathe in? Or do you have a tendency, what we find a lot is people's ribs tend to poke up when they breathe in and they arch their back actually away from the floor, that they're breathing and pushing their chest forward and lifting their chest rather than being able to kind of get the air down here. So once that is established, then the ribs are able to come back down into a better position. The diaphragm
down into that position, kind of wrapping down, isn't it?
Rather than sitting up here in that lordotic posture, putting pressure on the back, the ribs are able to come back down when we get that diaphragm working and the core working with it. Then you're able to reconnect with your core a little bit better. But until you get this angle better, it's really difficult because you're just fighting against the pull of your back and you're fighting against the position of the diaphragm.
It's all about strategies, isn't it? That back muscle, is, imagine it's talking really, really loudly that it wants to hold in that position, and because all of this has been stretched and your C-section, this isn't shouting loud enough to pull it down against it.
And the back is doing too much.
Yeah.
That's when issues like pelvic floor issues and diastasis can come into play as well. If you're
So just explain the diastasis a little bit better.
So the diastasis, I suppose, is a bit of a gapping or a pull in your linea alba, which is in between your two rectus abdominis muscles at the front, or it's kind of your six-pack muscles that you'd see. So basically what happens with that is whenever you are using different strategies to engage your core and different strategies to get pressure to stabilize your spine.
So using your back more, or kind of
not even actually overusing your rectus.
Oh, right, okay.
So whenever you overuse your rectus and underuse your deeper muscles, it does tend to feed into coming in combination with a tight back as well, and you are using your back, but it's commonly overusing your rectus, underusing your pelvic floor, your diaphragm, your breathing, and your deeper, you have your transverse abdominis muscles then, which are like a corset-like muscle, which is deep and wraps all the way around. So once we can get then the angle better, the pelvic floor connecting with the diaphragm as well and moving in that synchronization, then you're able to start to get that deeper trans-abs muscle to connect as well, which then takes the pressure off that rectus, because it's usually that, as you were saying, sometimes you get that bracing and the doming. So it's just a strategy of how they're creating stability, if they're kind of pushing out and bracing to create stability rather than getting everything to work and contract together to create stability. And that's when things start to come a little bit better. You start to see less of a dome because everything's working a little bit deeper.
Everything's drawing down in together.
Less pelvic floor issues because you're not pushing down. And if you imagine when you're creating that intrathoracic pressure, if you're kind of bracing and pushing out into your tummy, pushing down into your pelvic floor, pressure takes the path of least resistance. So if your pelvic floor is that little bit weaker, then that's when you might end up having leaks and stuff like that. So a lot of the time pelvic floor issues aren't only a weakness in the pelvic floor, it's a strategy issue and how they're managing the pressure in their system, and they're creating pressure to do daily things like lifting.
So they might have the strength, but they're just not using it together in the right format to create that massive stability. They're just not using it as well as they should do.
Exactly, yeah.
And what type, so if you were having somebody coming into for a first assessment, what type of we generally kind of ask people, right, what's the biggest issue that you have? And like, I know from some people who come into me, they'll be going, right, when I go to get up in the morning, I have to roll onto my side to get up. What do you kind of find is kind of most common with post-pregnancy female, let's say like 2 or 3 months after they have the baby? Is it kind of just that sitting up in the morning time, or is it kind of feeding times, or just general chores, or fatigue issues, or kind of energy levels?
Yeah, a lot of the time it's kind of, it would generally be things around kind of lifting the kids, bending down, cleaning, picking stuff up, things that they're having to do without maybe as much of a stable core as they had previously. And then that combined with that strategy that they developed during pregnancy of overusing their back, underusing their core, just kind of lingers then throughout. And then once you develop that strategy and that compensation, it kind of just becomes ingrained, and it's what you're used to doing. So it's the muscles that you use rather than getting the other muscles to kick in. So yeah, it's commonly like pain picking up the kids, pain lifting the kids out of the cot, or even breastfeeding. They might get neck and upper back pain because they're in this position, and everything that they're doing, they're holding, they're carrying, breastfeeding, everything's here rather than the back being able to open again.
That happens as well. If you like breastfeeding, we've seen a lot of females come in and chest will come forward, and then all of a sudden they're not getting enough sleep, and then their chest comes down and they slouch down in that position because they're so tired, and that's a natural posture that you take when you're tired. So all of these things kind of combine in together, not just one task. We start to look at the whole entire picture of what that person is doing during the day, how they're using those muscles, and then again, fatigue and energy levels comes into it, because you always want to be doing the best for your child, but then again, you got to look after yourself, because otherwise you're going to end up in a jock.
Yeah, definitely. Especially in those early days, I feel like people try and jump back into things very quickly, and they're
when
like,
should they jump back into kind of exercise?
Yeah, so I suppose like it's individual for everyone really. The benchmark, I suppose, when you go to your doctor, it's the 6-week check that is like, you know, and the typical is that you're told you're 6 weeks on, your tissue's probably healed, go do what you were doing before. So, but it's really not the case of being able to just jump back into things 6 weeks. Like, it's not a magic number that it's 6 weeks. It's dependent on if you had a C-section or not, what kind of delivery you had, if it was traumatic or not, how you're actually using your body, how are you developing those strategies, what your strength is like, and what you want to get back to doing. So I suppose, say for example, a lot of people come in and they want that timeline. They want that timeline of when can I start back, say running for example. And there's been new guidelines that have come out last year which are quite helpful in giving a rough guide, but then it is still very individual. And the guidelines kind of say that you should be at least 12 weeks, so at least 3 months before you even attempt to start running, because basically your tissue, whether it's your pelvic floor or your C-section, kind of takes at least 6 to 12 weeks to actually fully heal, so that for the tissue to heal, and then just to start to normalize everything and reconnect with your core. So what we would usually start to do first is kind of getting that reconnection of just awareness of posture, awareness of
recognizing what the problem is. First of all.
And a lot of people feel a disconnect to their pelvic floor and to their core and feel, I don't know where it is, I can't find
what
it.
Is this?
I don't know how to contract
Is I have a core?
Yeah, so it's how to find it, how to engage it again, then bringing that into more functional movements like squats, lunges. So the first couple of weeks you'd be doing like gentle pelvic floor, going for a walk. Then weeks 2 to 4 you can start maybe doing some squats, lunges, provided you don't have any issues or any symptoms, because there are things you have to do day to day. You have to squat down to pick things up.
And then women kind of take that for granted. They kind of go, oh, like I can't even walk 10 minutes before the pain comes on, and it's kind of going, oh, am I really that bad, or am I really that unfit? You've kind of gone through maybe like the 6 to 9 months carrying that extra weight, and you might not have moved as fast as you did before. So all of those muscle fibers that used to contract really, really quickly because you moved a little bit faster have started to kind of get a little bit lazy. So it's not a matter that you're not able to kind of walk that 5 or that 10 minutes without any pain. It's just that your body you haven't retrained it to do the same as you said, the strategies.
The compensation.
Yeah, and a lot of people, Sarah's quite good at kind of getting the nitty gritty, the fine tuning those muscles to get them working. And then what we do is when we bring them back into for the more strength and conditioning side of things, we start to look at how get those muscles to fire quite quickly again, rather than moving them quite slow. And some people might have heard me going on about your couch to 5K post pregnancy, that it's just basically walk 40 seconds or run 40 seconds, walk 20 seconds. I just don't agree with it, because it's more focusing on one type of muscle fiber type that's generally your slow contraction muscle fibers, and it just completely ignores how fast that nervous system needs to be able to work when you're running, which is like basically jumping from one foot to the other. So a combination of what Sarah does and what we do with the strength and conditioning really tends to help a lot of people along. And we've got stuck with a couple of girls that were very, very difficult to try and get back in, but I think that was the height issue that we kind of had one or two of them.
Yeah, a lot of the time when it's those issues as well, they're actually years post pregnancy, and that's when the problem arises, when you're using these compensation strategies.
Get it out there.
Compensation strategies for a long time. It's very hard to unlearn those compensations. So if you can get that early, and if you can maybe get like a checkup of how you're moving, how you're bracing, if you are ready to return back to running, because what we do is first look at the strategies that you're using to do day-to-day things, squats, lunges. Are you able to brace everything? Have a check if there's a diastasis, if there's any issues with your pelvic floor, things like that. But then also do a couple of tests to see, is your body ready to return to running, like how your strength is, so strength assessments, single leg assessments, balance, how your stability is, and then also things like impact tests. So are you able to hop on one leg for however
That's getting
long?
those muscles firing quite quickly,
But also recognizing, is there any symptoms? So like a lot of the time people might start to not do any of these tests and just start back into a little jog, and they feel their pelvic floor feels funny or heavy, or they might be leaking, and they kind of ignore it and they push on and they keep going. That's when it's a sure sign you need to stop and get a check, because that's the system and the strategy isn't right, or you're just not ready in there yet. So those tests are quite a good indicator of just, okay, how many hops can I do before I maybe do start to get a little bit of symptoms in the pelvic floor, get a little bit of pain, and just monitoring it that way. Because with this kind of thing, it's not a case of no pain, no gain, push through. It does get worse, and it does lead to issues like those women we were talking about. It's an issue further down the line rather than an immediate issue, and they're kind of like, I feel fine, I feel good, I have no pain, and they run, maybe push it a bit too much. Then that's when things break down, whether it's diastasis, pelvic floor, back pain, that kind of lingers a little bit.
And it really is individual. Like we had a couple of tricky patients that we're just kind of trying to figure out exactly problem solve, myself and Sarah problem solve what was going on. And like we did everything, we followed things by the protocols, we did everything by the book, and then all of a sudden she just was not getting better. So this is when we have to start to think outside the box. And this girl, she's very, very strong. She was well able to complete all the movements that we got her to do, but she was just fatiguing in that core quite quickly. So what we did was we just worked on that core a little bit better, but instead of sending her out for the slower runs, I got her to do a 10-second fast run, and then that started clicking all those muscles together. The system started working together a little bit better, and we just got them back to where they needed to be. But it took a little bit longer. She was on a 12-week program, but we're working with her for like 14-15 weeks or something like that just to get her there. But all those strategies are kind of very good. So like just to summarize it up, number one, give me a little rope here. Number one, you want to get those muscles to fire. You want to get the diaphragm, your pelvic floor to work together.
Yeah, you're looking at the posture as well. So you have to get that angle back of if your rib cage cannot come back over your pelvis. If you think about that kind of synchronization of your diaphragm and your pelvic floor, if your rib cage is sitting forward, your diaphragm's kind of here. If you're tilted in your pelvis, which is generally where people end up, your pelvic floor is back here. So your diaphragm's up here, your pelvic floor is back here, so you can't get that synchronization, and that's when you end up having pelvic floor and diastasis issues and low back pain. Whereas if you can get the ribs back in, the tailbone back tucked underneath you, so you're engaging here a little bit more and they can sit on top of each other, and then you have it just, you imagine like a canister of support, like a can of Coke, it's top lid, bottom of the can, and canister around, so that you want to get that it's as stable as it can be when everything's stacked on top of each other and the can is full, rather than if the top of the lid is open. Because
the core is designed to transmit force. It's not trying to absorb force. It transmits it from your legs to your shoulders and acts as that go between. And a lot of people think they're going, oh right, so I can do 50 sit-ups.
Yeah.
It's not a good representation of what that core can do if you can't manage it functionally. So we have the pelvic diaphragm floor, or you have the diaphragm, you have the pelvic floor, you have those muscles working in together, you start to get a little bit stronger around there.
Getting them connecting at the same time, working together would be the first thing, yeah.
First thing, get them in together, then we start to look at a little bit more functional movements and strength. Once we get the ability to hold yourself in one position, like your isometrics, that's when you kind of go to first, or would you kind of go to other ones?
No, you will be, but you'll be looking at that with maintaining the kind of stability in and around the core that you
creating that tension.
Created. So anything that we then to go on do, say it's squats, lunges, or then your typical strength exercises, you'd also want to be looking at the tummy to see are they doming, to see are they using a core strategy as they're doing those. So it's coming away from then learning how to do it. It should be natural then at that stage. Then when you're doing all this, you're still keeping an eye on the pelvic floor, keeping an eye on the tummy and the strategies that they're using to create.
So they might be able to do it on the flat and not under stress, but then you put them in a functional position, they'll go back to their old ways.
So you want to constantly keeping an eye, constantly asking are they feeling symptoms, and constantly just looking at how they're creating that stability and that force, whether it's using that good strategy that you've kind of started off learning. And once they start to do other things, it just goes out the window, or they're able to maintain that. And that's how we then we want people to do as much as they can do and get back to doing what they can do as quickly as possible. So that's where you're always just, safely. So you're bringing them to that point that they can tolerate and do it well and safely without a compensation, and then loading them there. Then once they get a little bit better there, then you can progress on. And then it's a case of once you get that strength back, then you're looking at getting the stability back and the kind of control of the leg. So single leg stuff, because obviously if you think about running, it's a single leg activity, but it's also an impact activity. Okay. And then being able to tolerate that load a little bit higher as well with the impact.
Build a little bit of endurance onto it as well.
Yeah.
And what people, a lot of females, they tend to get frustrated with the progress because they feel, I should be progressing a little bit quicker. But we've had people come in where they just shoot off the charts, just really, really well, do so well through the first couple of stages of it. And then when we get to the running part of it, that endurance is not there.
Yeah.
Whereas we have other people where start off really, really slow, and we could be 6 or 8 weeks getting them back to just a baseline where we need them to be before we start them to run. So what we're trying to say is the path to recovery, it's never a straight line. It's always up and down. You always fuck it up, and you always kind of have some sort of step back into it, and that's normal for you, but it's being able to recognize it and not get disheartened by it.
Yeah, and I think especially post-pregnancy, like, women are quite hard on themselves, and there's just not a lot of education out there on how long it actually does take, as in it's literally 12 weeks until you're actually healed, and then you have to relearn the strategies and do all of that, get stronger again after not really using your body as much as you could. And even whether you were continuing to train through pregnancy, it generally a lot of the time doesn't translate to post-pregnancy anyway, because sometimes you actually get more stability from the baby. It can just change totally that your training strategies then. So it does take a long time to relearn everything. That's
an interesting one. After you've had the baby, there is that open space there where that fluid was actually creating the stability for you, and then that's gone. And now all of a sudden you're kind of going, I used to be fucking stronger, and now I'm not. And then you're looking out the window and Mary had the baby 3 weeks ago and she's flying on the road.
And it does vary person to person. It varies on your baseline, what you were doing before, how your strength is. Some people use these poor strategies even before they get pregnant, so then it just
long term.
And then it just fires up after pregnancy. If they're already using them a little bit more, it can exaggerate. Some people might have an old injury and they find that it comes back after pregnancy, because again it's coming back to that poor patterning of loading and strategies. So it really varies person to person. That's why they have a guide of how to progress. They have a guide of the tests that you can use to know if you're ready. And a guide of the timelines, but really it's a very individualized, having to look at you, having to see what you're feeling, see what you're doing and how you're loading yourself, and if you're safe and ready to go back.
Good. Okay, so what we can probably wrap this up a little bit more is we want to get more information out there for the people that are kind of suffering with these sort of issues. So what we have is there's a free webinar on Teachable that I'm going to post a link to on the bottom of this post, and that will give you a lot of information in regards to Sarah, what she does. There's a 30-minute presentation there on post-pregnancy, which will cover a lot of the stuff, but a little bit more details.
Similar idea, but I suppose just talking through maybe how to even do your pelvic floor exercises if you weren't sure exactly how to do that. It talks through that and it talks a little bit more detail into those posture changes.
Perfect. So we'll put a link up in that post, and we hope you got some information out of this. And from me, Fred, and Sarah, we'll see you soon.
See you soon.